Good morning.
Okay, so I think we can start our session. And good morning, everybody, for being here. And Dr. Hassan is going to speak, and this is a pediatric retina session. He's going to speak on laser versus anti-VEGF. I think this is the most important topic that we are confronted today. Both the parents, the neonatologists, and the doctors are asking this question: why not laser? Why not anti-VEGF? If you say one, they will say why not the other. So let's hear from Dr. Hassan.
Assalamu alaikum. Good morning, everyone. I hope that we can summarize the treatment for the ROB through this lecture. No financial disclosure. Understanding of the history of the ROB. This is a very important slide for me because this summarizes the classification for the ROB history, even the treatment. From the beginning, you can see that through the ICROB classification, you can find the cryo and the early treatment which used the destructive for the retina. It was looking for the better anatomical outcome. In 2005, it was that the ICROB give us the definition for the aggressive posterior ROB. Then after that, we are looking for using the VEGF. The BEAT study was 2011, approved the rule of the VEGF in Zone 1. But still didn't take any approval because of the systemic effect. Then the CARE study is very important, comparing between two doses of ranibizumab. Then the RAINBOW study, this is one of the most important studies which we can depend on treating the ROB because it's look after doses and compare it by another arm by laser and look after the systemic effect. Even they look after the neurodevelopmental of the child, and even they have extension for 5 years. We look after that. It could be the result coming with this 3 month or 4 month. And the ICROB study, the ICROB classification, the 3 edition was very important because after this study, they give us now a new definition for the treatment or follow-up or even classification for the disease. The Firefly study, which give the rule of aflibercept in the ROB, it's already published the 1 year, the 24 months recently. And as I said, the RAINBOW extension is still there, and we look after this result, very important for us. Just to understand the situation, why we are shifting from laser to anti-VEGF. If you go for this destructive treatment, it was looking for the unfavorable anatomical outcome. But through this study, they concur that in unfavorable outcomes, it will be increases when the disease is posterior, even there is a plus. And just for some, that the disease type 1, type 2, which come from the early treatment, the points when we treat, when we observe. When we look at what our goals from the treatment from ROB. The first thing is that we need better anatomical outcome because through the previous studies. The second one is the better visual function, which is very important for the children. And you put in your mind that these premature will be affected by the disease, prematurity. Sometimes it will be neurological, sometimes it will be ophthalmic as anatomical foveal change, or sometimes it will be even developmental. Less side effect. This is very important because you want the medication didn't affect other organs. The BEAT studies, it's approved that in Zone 1, Stage 3 is bevacizumab is better than laser. In the Zone 2 posterior, and here just I want to mention that the Zone posterior here was, the definition of the Zone 2 posterior was coming from this study as a beginning. So they use it in Zone 2 posterior, they found it is not clinically significant better than laser, but not inferior for the laser. And you can if you go look at the study in detail, you can see that the worst anatomical outcome coming from the laser group always. Another real-world live data will give you that the posterior location of the disease give you high myopia and amblyopia for the children. Then the safety of the disease. The problem was the dose. There is any solution? Yes, this is 2 days back published. We are looking for this study. It will come from the Pediatric Eye Disease Investigator Group. They use low doses and very low doses. And they approve that they reach even 4 microgram from Avastin, they approve that there is rule to treatment. And what we discovered, they don't compare it by the laser. They use the laser as a screw treatment, but they compare between the medications. And they found that, sorry about this. I will go back. The safety of the disease, because this medication is affected to suppress the VEGF around 3 months. Again, there is some meta-analysis approved that there is rule in the impairment of cognitive of the children, impair of the language scores. Another data came for us. They said, no, there is no effect. So we are still in dilemma, debate that this will affect it or no. This is the very important study which I mentioned that just recently published. They approved that the low doses of Avastin is better, is a good result. Even very low doses will be even have effective, and the recurrence or reactivation, as according to the ICROB3, didn't affected by the primary dose, but it will become earlier in the very low doses. The aflibercept study, this is the Firefly. It's approved that the primary success rate was better in aflibercept than laser, but sadly they didn't meet the non-inferiority criteria which they are looking for. So there is extension for this study, and there is review for the data more. As I said, the KAIROS study comparing between 2 doses, 0.1 milligram of the ranibizumab and 0.2, and the systemic effect of 2 doses is the same, around 4 weeks suppression. And here there is one result coming from this study. They said the baby who received, the preterm who received the smallest or the lowest dose has better chance to have fully vascularized retina. But this didn't come from the Rainbow study, which even look at this, they didn't come as a clear evidence that low doses, because this Rainbow study compared between the 2 doses and the other arm was the laser. So we can't depend on this study as for the dose, for the recurrence, and compare it by the laser. And if you go for the results, you can find that the ranibizumab was better than laser in the 0.2 milligram dose. And about the primary, the treatment success, it was comprehensive, because it looked after the recurrence, it looked after the anatomical outcome, and even the safety of the baby, because should be even survivor preterm. Again, here's the rainbow safety. The systemic effect of the anti-VEGF was like the same as the laser arm group. Then 2019, they got the approval from the MEA to be used in the treatment for the ROB. Here is that after they wanted to extend, because this is very important for us, because this is the first paper came from the Rainbow study about the evaluation of the neurodevelopmental around the questionnaire about the quality of life for the children because of the vision. And it was that clinically significant in the laser group and less myopia. About the ICROB classification, I mentioned here 2 things. Posterior zone 2, because we will use it. It looked like that is very important for us in our real life. And reactivation, the recurrence, the reactivation. So any change in the guidelines, because before we was using this medication, but no one changed the guidelines. Always it come as different paragraph. Laser is the main treatment for the ROB, and you can use the anti-VEGF according to some precautions. You can see the UK guideline to 2022. They mention clearly zone 1, zone 2 posterior, anti-VEGF is the treatment unless the baby has periocular infection. And zone 2 mid or anterior, you can use the laser. Even they mention that any avascular area can be treated by the laser or argon laser in this case in situation. So just to summarize what's the new, through this new studies which use the anti-VEGF, in zone 1, anti-VEGF is the treatment, and zone 2 posterior, because they found that will be better visual outcome, anatomical outcome. Laser is for the zone 2 mid and anterior, and for the bar lesion with persistent avascular retina. And even the laser, if you can't guarantee that the baby will follow up with you, just he will maybe travel. You should do the laser for the baby in any zone was. And periocular infection, you should be aware about that, because most of the report about endophthalmitis in these cases came from baby who has conjunctivitis or periocular infection. And reactivation with fibrosis, you should use the laser better than use the injection. Thank you very much.
Thank you. So are there any questions? Yeah, go ahead. Yeah, you can come up here.
Yeah, now we are giving half of the dose of the adult dose for the Avastin for preterm. Now they are reducing the dose for the safety. So what is the recommended dose now?
About the Avastin, still I can't tell you that you can reduce the dose, because the evidence now came, they said this is in the first year published report. They use it low doses. They found there is effective, but this I can't tell you the good result anatomical. There is reactivation around 30% of the cases, even more than 30 cases. It's effective, but you need re-injection. There is no rescue result unless the patient has a vascular area, no activity. If in case of recurrence, you should use the same dose.
Okay, thank you.
Maybe you can have show of hands. How many are using half dose Avastin? And how many are using 1/3 dose? Yeah, so I'm using about 1/3 dose. We did dosing in our institute, and we found that if we go below 1/4, then we were having more problems. So between half to 1/3 is what we are using. Yeah, that's what we have published also.
The low doses began from 250
yeah, if
micrograms.
you go much lower, because there were studies showing that even 1/10 dose is effective. It still has good activity, but this is the problem, that then they have more recurrence and less efficacy than. I only use Avastin. I don't like Lucentis aflibercept because of the data. The data shows that Lucentis had 40% recurrence, and my problem with Lucentis is that the dose which is approved is a smaller dose than what they sell. So they're not selling pediatric dose. So the parents are buying adult dose for 2 eyes, and then we are injecting that. So the parents are at a loss. They have to purchase the adult dose, but we are using only the pediatric dose. They should market pediatric dose. When there are pediatric suspensions, pediatric tablets, so if the drug is approved for pediatric dose, then they should be marketed as pediatric dose. That is my problem. So parents are paying 2 times for what is not going to be used in their kid, and then there's a 40% recurrence, which means they still have to buy another 2 doses. So they are paying 6 to 8 times of what their child actually needs. We should pressurize the company to market pediatric dose, because that is what has been approved. So we are forced to allocate or draw that much only what we have to give from an adult dose vial. That's not fair to my mind. And as I said that, the recurrence rate, even in Rainbow, it was so high, and many of the colleagues who have been using, they have been saying that they then still have to struggle to give either laser again or another dose. And, so that is my problem. With Avastin, the recurrence rate is less than 10%, which means only few patients I have to, re-inject or do additional laser. About aflibercept, I don't have any experience, so people who have.
I am using 1/4 of the adult dose, that is 0.625. Yes, Avastin. And it will be very difficult to use half of this dose practically. I think it will be something impossible. Yeah. It will be possible sometimes. And are you injecting in the OP or you are injecting in the NICU, please? Both eyes, madam.
So one of the problems we faced, because this is what was told, that if there's a periocular infection, now if it's conjunctivitis, it's okay, you will treat for 4-5 days, and after 5 days also you can give. But my problem is the NLD block. So I had these babies who had very severe zone APROP, like hardly any retina formed, and then they have an NLD block. So I was, struggling with my oculoplasty colleagues. Can you do probing, syringing, and open that NLD so that after 2 days, 3 days, I can inject? So there were a couple of babies, we could do that. But then there were few babies who were not fit for anesthesia because they're still in the incubator. And so what we did was, under topical, we could do the probing by an experienced person, and then after 3 days, we could inject. So that becomes a clinical challenge. We can publish
Dr.
that.
Subhadra, I want to excuse you. About the doses and using the doses or the follow-up or recurrence. For us, even for me before these data come, the recurrence was a huge problem. Even I consider it as a failure of the treatment for me, and I will go directly for the laser. But if you review these data, they mentioned that they wanted the minimum dose, which give effect to the patient, reduce the disease. Even they put in their mind there is reactivation. The recurrence, it will happen. So you will go for the laser or re-injection. So here they open the gate for the re-injection if the patient was in zone 2 posterior or zone 1. Before we was in the BETA study, if there is any recurrence, you should use the laser directly. But in the ranibizumab or in the Rainbow study, even the Firefly, they use even this in the low doses from bevacizumab. They use for the reactivation in the patient in the zone 1 or zone 2 posterior. They use again the medication second time, even third time, because they found that it will be better results for the vision.
The other problem clinically which I face is that somebody has given ranibizumab, it has not worked, or there's a recurrence. Now can I inject bevacizumab? So I did that. I was little skeptical whether an eye which has received Lucentis, can I now give Avastin? Because that Lucentis didn't work, because I give only Avastin. So I have done that. That seemed to be working pretty good. So there was no clash between these two drugs in the vitreous as far as I could see. But these are only few patients. But we might face that type of situation. So in adults we are switching. So we don't know in children how it will behave, but that was another clinical situation which I had to take a call.
Thank you very much.
Thank you, Dr. Subhadra and Dr. Hassan. Next, we would like to invite Dr. Subhadra to give a talk on tips and pitfalls in ROP surgery. Thank you.
Okay, I hope this will work. Thank you, Dr. Rao, for helping me set this up. And I'm going to be very brief because people are going to talk about the surgery itself. I think we have to realize that the ROP detachments are very variable. Most of them are tractional, almost 90% of them are tractional, which means you don't need any tamponade and they will not get PVR. And you just need to relieve that traction. But some of them will have an exudative component either alone or with the tractional detachment. And we don't know why this exudative component happens only in selected patients. We don't have an answer. And more recently, I've been recognizing that even in the acute phase, you can have a reg component to the stage 4A, B, or 5. And that's little difficult to pick up because you will see a convexity in addition to the concavity of the traction. And we need to identify these eyes. And almost all of them are bilateral. And mostly it will start within 2 to 3 months of age. It will start earlier in more posterior disease. And it can have various configurations. I'll be coming to some of that. It's important that, we need to have a differential diagnosis, most important of retinoblastoma. Fortunately, in neonates, retinoblastoma presenting as leukocoria is very rare. Most of the neonatal retinoblastoma will be like a macular lesion or a peripapillary lesion. It will not be like a total detachment, which you see in little older children. But yes, that should be a consideration, and we should do ultrasound in all these eyes and, document along with immersion scan that there was no calcification. Then, of course, like persistent fetal vasculature, FEVR, viral retinitis, this is something very common in our country. It may not be very common in all communities because of poor menstrual hygiene. We have a lot of torch infections, HSV, CMV, and then, of course, rare conditions of endogenous endophthalmitis or systemic disorders. Now, one thing we have to remember is that almost all these detachments in ROP, they are progressive, and the vision and the potential vision will progressively decline. So these are relative emergencies and we should operate them as quickly as possible. So the selection of surgical techniques, so there are various techniques that I have been using over the last 25 years that I have been doing this, and each of them has their own indication and their own way, but the most important is the observation. There are eyes which you will not operate, and I will show some of them, but almost all eyes, if parents are ready, I am ready. We will take up for surgery, howsoever bad is the case, howsoever challenging is the case. So belt buckle, the utility has reduced, but it still has a utility. This is one patient, he is one-eyed, and he had laser, the traction was increasing, peripheral traction, and we have put a belt. He is now 25 years old, and when we put it, at 5 years, you can see his writing was good, and he uses telescope to read and write. So most of these belt buckles you put there around the equator, and if you have seen how your grandmother used to wrap wool ball, so you cannot wrap a wool ball right at the equator. You have to make it oblique. So here also, because the traction would be more posterior temporally usually, rarely it is in other quadrants, but mostly it's a temporal traction which is posterior. So you put it posterior to the equator on the temporal side and little anterior to the equator on the nasal side. And there's a controversy whether this should be released or removed. We can discuss that, but I have stopped removing these buckles as an optional thing. It's optional. Only few cases I release. I don't remove all these buckles. Then the other thing is that one has to remember that these are very rapidly progressive detachments. Unlike in adult diabetic patients where, if the nasal retina is detached, we can wait and watch. So that was my thinking in this case when I started. So I can see that, most of it is well lasered. There's just a tiny area detached. So I said, okay, let me observe. After 1 week, you see how it has changed. It has started closing the funnel there. This is because there's a persistent fetal vasculature stock. I'll be talking about this more in the macular surgery session. And you can see, and within 5 days, you can see the whole thing has just come up and attached to the lens, and now I'm in danger of having to sacrifice the lens. And we operated same day. But I think on hindsight, I should have operated in the first visit itself. So remember that if you have a traction, and Michael Tracy says if it is more than 3 clock hours, these tractions are going to rapidly progress. And so you need to operate them at this stage where the macula was not affected, where it was much easier to operate than, land up into something where then you have to operate it in an emergency. You can also have bleb-like posterior detachments. You can look at this publication by Tapas. So these patients present with closed funnels. They are very fulminant. There's hardly any retinal tissue visible. But many of these eyes we can still salvage. We give anti-VEGF, do the laser same day, and within 2-3 days, make them ready and then do the surgery. During surgery, don't touch the folded retina. Just remove the vitreous scaffold around it, and you will be surprised at the outcomes. But many of these eyes we get lost. You can see here, they can have significant fibrosis where we are not able to salvage, but still a number of these eyes we can salvage by sequential anti-VEGF laser and surgery in quick succession without waiting. I talked about exudative RD, so you can have exudative RD. When I saw this case, this patient had pseudomonas in the blood, and I thought this is end off. So the left eye, I did a vitreous biopsy, vitrectomy, and injected anti-VEGF during surgery, but it didn't grow anything. My colleague told for the other eye, don't do anything, just inject. So we injected anti-VEGF and everything went away, and then we did laser. So we have published a whole series of these exudative detachments. We don't know why they happen, only in some cases, but they do extremely well with anti-VEGF followed by laser. So the important thing for these detachments is that if you are not a surgeon and you are just doing the lasers or screening, the moment you see that the ridge is elevating, either with or without laser or anti-VEGF, then don't wait. Just get the hemogram done. We found 90% of these babies are anemic. They have hemoglobin of 6, 7, 8. I don't know whether that is the cause or effect or whatever it is. Almost everybody needed transfusion before surgery. So get their hemogram, get them transfused, and then send them immediately. Don't wait. If we do surgery at this stage, which is 4A, they have universally very good results. Surgery is 15 minutes. Challenge is the anesthesia and the post-anesthesia care, but surgery itself, any good retina surgeon can do these surgeries if they just observe some of their colleagues how they do. So I'm not going to talk about these surgeries because somebody else is going to talk about it, but just to say that this is your battlefield, this is the area where you can operate. If anything is outside this, then you'll have to sacrifice the lens. So this is my current technique. We put a bolster at the edge, so that there's a pediatric set available by Alcon, but that is too expensive. So we are just using the normal adult set, 23 gauge or 25 gauge. We put this band, the belt buckle band there. So actually the belt buckle that I use for adults, I cut a little piece and leave it for my babies. And we can insert that. The only challenge is that your assistant should not push that cannula. It's very close to the lens. If it starts coming out, there's a tendency to have the assistant push it, and if they push it themselves, it will just go and touch the lens and create a cataract. So be very careful about that cannula. That is the main problem. It can come out and cause choroidal. If choroidal happens, just stop the surgery. It will go away on its own. You don't have to do anything. But, that is the main challenge is of the cannula, that it should not come out, or you should not be having a problem with that. And during surgery, the instruments are kept vertical, both the illumination. You can use a biome, you can use a contact lens. I am using a wide field contact lens for my surgeries. You see a cotton wick has been placed in the fornix. This is very essential part of the surgery. If you don't put that cotton wick there, it should be very thin. If it is thick, it will swell up and push that cannula out. It should be thin so that it drains away all the water. And once you're doing surgery, the only challenge is to identify sometimes a peripheral retinal schisis. Mostly these bands, these vitreous things you can remove. You can use Tramslone if you like to use that. Many times this vitreous is colored by blood, so you can actually see the yellow blood. But as you're going to the periphery, sometimes it's very difficult to know, and I get challenged there. I have made mistakes. If there's a schisis and you're cutting the schisis, or are you cutting the membrane? So that's the only challenge, and less is better in ROP surgery. If you're in doubt, just stop. So this is another case. If you find, so before we start the surgery, we check where is the attachment of the retina. Just depress the periphery and you will see. So the area wherever it is attached, you can't enter. If it is less than 180 degree, you can enter nasally or you can enter superiorly. But if it is more, then you need to remove that lens. You need to enter through the lens, remove the lens. And here you see we segment. We usually don't peel in these eyes because the underlying retina is very thin, and you just remove all those attachments. Wherever you can't remove, just leave it. You can use scissors, you can use forceps, you can use your cutter, and try to remove all the areas that. So here I'm using the scissors to remove the posterior hyaloid. You can remove the posterior hyaloid in many of these eyes, not in all eyes. So you have to make a judgment by using your cutter and scissors, and then you close at the end of the surgery with under air. What happens if you create a break? So this patient, actually I gave Avastin, and next day she came with a bullous Raygardi. She was one of the triplets. Laser had been done. After laser, it was not responding. So I gave injection, and next day, because of PVD, she developed a break. So now if they have a very localized break, then I just do a localized ILM peel and a localized vitrectomy. I don't go and do everything there. Just it's a 15-minute surgery. You can see you can do the ILM peel in these children, and then you can just exchange with oil, and you can remove the oil in a week's time. So this is after removing the oil in a week's time, and the retina is attached. Almost all of them will develop cataract within 6 months to 12 years, and then you also need to give patching treatment. So remember, if you do only one eye surgery, they will develop very rapid myopia within 3 to 4 months, and you will need to manage that. Now coming to stage 5, these are bilateral diseases. Many of them come with corneal scarring because they have come late. They have been referred late. So it's a progressive condition. Always do an examination under anesthesia before you start surgery. So this patient was referred as stage 5. Actually it had stage 4B. So, so we need to do a detailed examination. I'm not going into the surgery, but just to say that, you operate, I do bilateral simultaneous stage 5 surgeries for many years, and it takes between 2 to 3 hours for the 2 eyes. Initially it used to take 4 hours each eye. Now it's very fast. And important thing is after surgery, give them glasses and train the parents how to do the vision stimulation exercises. You'll be surprised that, within 4 to 6 weeks, the children will start seeing, they will start grabbing things, and they start developing these visual connections quite early, and it's quite gratifying to see that they are seeing and they can see. We also do open sky vitrectomy. I was very fortunate to learn from Dr. Hiroshi the open sky surgery. Again, this can be done along with your cornea colleagues using a cover slip, the same cover slip which you use for microbiology. So after removing the cornea and the lens, you put the cover slip, sterile cover slip, and under that you can go ahead and do all the maneuvers and then fill it up with Helon or Visco and then put the graft back. Then more recently I have been doing modified scleral imbrication. I'm not going to show that whole surgery, I have shown it before. Those who are interested, I can show. And here you make the flaps and tighten the sclera and then put a buckle. This is what will happen. So this patient came from Bangladesh. I didn't want to do a vitrectomy in this patient. I have just done no intraocular surgery, only a buckle with imbrication. You can see after 1 year, the whole retina has gone back, the fold has opened up, the whole ROP has gone. So that's very nice. Another patient who came with reg RD many years after initial ROP regression, and you can see here the retina was detached, no intraocular surgery, external, single procedure, no oil. The retina attached and patient got good vision. And then we put them on low vision aids. So what are the eyes which we don't do surgery? So as I said, every eye we operate except relative contraindication. If it is unilateral stage 5, I am a little reluctant to do that surgery. If there is a complete retinal dysplasia like this one, there's no vessels seen in the retina, the whole retina is folded and there's no vascularity, then that eye we won't do. If there's an obvious optic atrophy like post-hydrocephalus or PVL. If there's extensive subretinal echos, if there's a lot of cholesterol under the retina, then I don't do, although if I do, they still get light perception and color vision. And then, of course, if it's a burnt out pathology. So how do you know it's a burnt out pathology? You can compare these two. This is active. There's new vessels there, active vessels there. So this is going to progress. Whereas something like this at 1.5 or 2 years, this is not going to progress. It's already fibrosed and it's going to be, stable. So this is one case that I did. Just I wanted to show. So it's not that unilateral stage 5 we don't do. If the parents are compliant, then see this child, she's from Philippines, we have done unilateral stage 5 surgery, and what is the vision she's having? She's able to, really play well with her good eye closed, and the parents are really working hard with her. She's not wearing contact lens, she's wearing a phakic glass, and you can see that, very nicely she's able to play and put those things in their holes, and so she has about 3/60 or 4/60 vision. So yes, they can attain that vision with your aphakic correction and the training by the parents. Some children will get good reading vision also. We have parental support groups for these children, of course. And so I want to conclude by saying that what Hiroshi said in 1960s when he started ROP work, that these are the most difficult detachments that a retina surgeon does. I want to break that myth and say something, if I can do, everybody can do. So, people can do it. It's only a question of attitude. And more the people do, we'll have better instrumentation, we'll have better outcomes, we'll have better thought process of how to handle these cases. Don't think of the pathology, think of the possibilities. Like this tree in our garden in LV Prasad Eye Institute, it looked dead. But when we transplanted it into another garden of ours, it bloomed. Thank you so much.
Thank you, Dr. Subhadra. Excellent presentation, a lot of new information. And now I'd like to request Dr. Prasanna Rao to please come and give his presentation of surgeries in stage 4 ROP. Please take the stage. Thank you.
At the outset, let me thank Miom and Dr. Amri for giving this opportunity. In fact, after Dr. Subhadra's talk, I don't think so I can add much to... after Dr. Subhadra's talk, I don't think so I can add much, so I'll just quickly go over my presentation. So, stage 4, as you all know, is scar tissue which causes enough traction to create a subtotal detachment, and we have two types here. Stage 4A where the macula is not involved, stage 4B where the macula is involved. And as Dr. Subhadra said, this is the stage where you can actually salvage vision, and probably the last stage where you can do something good for the baby. So management would be stage 4A, if it's extramacular away from the macula, you would probably observe and you wouldn't consider buckles for very anterior ROPs. And if it's extramacular threatening or involving the macula, then you do a lens sparing. If it's 4B and a recent macular detachment, then you go ahead with the vitrectomy. If it's established long-standing, then probably observe. Lens sparing vitrectomy has an advantage because you leave the lens behind, so this helps in early rehabilitation. When you do a lensectomy vitrectomy, most of these patients you leave them aphakic, so the development is usually impaired. Scale buckles, on the other hand, cause myopic shift, so there's more trend towards doing lens sparing vitrectomies nowadays. Anatomical and functional outcomes in 4A are very good, almost 82 to 90% success with a mean follow-up of about a year. So what's special about vitrectomies in neonates? So the important thing is the distance of the sclerotomy. It's got to be 1.5 millimeters, and it's usually in the pars plicata because the pars plana is not developed. So the entry sites can be pars plicata, limbal, or iris root, depending on the availability of the space between the lens and the anteriorly dragged retina. So this depends on the vector forces between the ridge and the ciliary body and the ridge and the posterior surface of the lens. The lens is relatively larger, so the instruments have to be kept usually parallel to the visual axis. PVD cannot be achieved in all the patients, though you can attempt, and iatrogenic breaks are usually poorly tolerated and may contribute to surgical failure. So what are the principles? Preserve the lens as much as possible, relieve traction, and the main two sites where you get traction is around the optic disc and the ridge. So the optic disc to the ridge traction, or you can have this central stalk which goes to the drum head between the two ridges. And at the ridge level, you will have ridge to ridge, you will have ridge to the wall, ridge to the ciliary body, and even ridge to the lens. So these are two main areas where you need to concentrate on. As is always said, less is more in these patients. Remove as much as vitreous as possible, avoiding a break. And if it's tightly adherent fibrovascular polyfusion, you probably leave it rather than creating a break. Attempt PVD only if you can, you're not too aggressive in these patients, and I generally use a lot of triamcinolone in these patients. So before I start the surgery, I want to see the site where I'm going to put my instruments. Is there enough space or no? That can be done via indirect, or as Dr. Subhadra said, you can use a forceps and just depress. You avoid sclerotomies in these meridia, limited peritomy. I place a pre-placed suture when I'm putting the infusion, and you have the option of using a short length trocar. Unfortunately, we don't have that option here, and I always suture the sclerotomies at the end of the surgery. So this is a quick video, not much to say. So this is a patient who had sort of a 4B year, and then after surgery, we removed the vitreous as much as possible. And this was one of my initial cases, almost about 6-7 years back, and this is how it looked like. So at the end, we did fluid air exchange and closed the case. Unfortunately, this patient developed a post-hiatal contraction at the age of about 4-5 years and had a recurrent detachment. At which point of time, I referred this patient. The patient went to India, and he got a scleral buckle done by Dr. Pramod at Shankar Netralaya, and this is how it looks like. So probably there was some hydroid remaining behind, which can contract and which can cause this. This patient just followed up over a few days back, vision of about 20/60 in this eye, and the other eye is very good. So do tend to have good visual outcomes in these patients. This is another patient having a nasal detachment, and you can see those folds here, and these were all removed. I used triamcinolone, tried to induce a little PVD here, could manage a little removal of the PVD. So this is another patient. I'll just go quickly over the third patient here. Similar kind of a situation. Again, you can see the temporal ridge here. When you try to induce PVD in these patients, sometimes you can achieve it, but sometimes you'll find that the retina is actually getting lifted, in which case you probably just leave it as it is. You just trim the vitreous as much as you can. So this is what I was trying to do, trying to lift here. And you'll find that this part of the retina is getting lifted, and when that happens, you just leave it rather than creating a break. So a quick conclusion here, the lessons which I have learned from my short experience are, this surgery is the surgery where the surgeon needs to know exactly where to stop. Perfect is the enemy of good. You don't want to drain the fluid, you just leave the retina as it is. No breaks. So if you don't need any breaks, create any breaks, most of these are tractional detachment, they will settle on their own. And less is always more in ROP surgery, and avoid retinal breaks as much as possible. So thank you for your kind attention.
Very nice. I think the only point I want to add is that when we are doing the surgery, we should always change hands and do from the other side. Sometimes people miss that out because it seems we have done everything, but actually there's a lot of vitreous on the other side also. So every time we should, take that effort to change the hands and do vitrectomy from the other side.
So in adult patients, you don't go beyond the equator on the other side. In ROP, you don't cross the midline with your instruments. Thank you.
My pleasure to invite Dr. Ahmed Habib now to talk about surgery in ROP stage 5. Very nice.
So a little bit more bleak, going to stage 5 ROP surgery. I'm Ahmed Habib from Egypt, Ain Shams University. I would like to share with you our experience in stage 5 ROP surgery. And first, the first question you're asked by the patient, by the parents is, what does my baby need and what is the success rate? So you're faced with a question that can take two answers. Either you say nothing to be done and your baby will be blind, or we can do something. So in my counseling, I only tell the truth. I don't give false hopes. I don't also take the whole hope out of the parents. I should arm myself with evidence-based data. I say some numbers to support my idea. I point out the possible need of multiple surgeries. And this is a very important step. And I make it a little bit bleak, but not hopeless. And I also give my advice. If I see that one eye is very good and the other has stage 5, I give my advice not to do surgery. But if the baby has the bilateral stage 5 ROP, I usually advise for surgery. So the evidence-based data here is the best reported results are the anatomical success of 30 to 35%. This is the best reported results. And the retina attachment here, we mean that a part of the retina is attached, not the whole retina. Usually the retina is longer or taking the surface area more than the eye itself. And 65% detached. The visual results, usually the best reported, are the 75% light perception. That means that even in detached retinas, light perception can be present, and this is also significant for the baby to know the difference between the day and the night, a difference for his sleep, his immune system. It is significant for him. 5% of those having form vision, and by form vision I mean the shapes that can let the baby walk around or catch objects. So there are different severity levels of stage 5 ROP. I did this slide a bit earlier than the ICROP 3 before restaging the stage 5 ROP into stage A and B and C. A being an open funnel, 5B being a closed funnel, and the 5C, the ugly one, with anterior segment abnormalities. So there are open and closed funnels, or a combination of both. Usually there are retinal folds that can be twisted around itself, and in posteriorly narrow funnels, the thick vitreous condensation form a central stalk attached usually to the disc. And this is important during surgery to identify the central stalk and to remove it if you can. So let's go on with the surgery. I usually enter through the limbal approach. I don't enter through the iris route. I have tried it and made some complications, so I enter into the limbus and I remove the whole capsule. I used to leave some of the capsule, but the Elschnig pearls were all over the place. I do some iridectomy to see the periphery, and this is very important. I will tell you why. Then I use a two forceps technique to start to remove the individual vitreous fibers. I know it's a tedious job and difficult and boring, but this is the way we could do it. We have a little bit of a plan to remove the mid-peripheral fibrosis, then the central, then the periphery. So mid-periphery, center, periphery. You can use You can use a chandelier, the dork one, the very tiny one, but sometimes it moves, so we don't usually use it much. Here, the Ingenuity has been adding more depth of focus, so I am able now to work with an external light into the center and deeper into the eye. So the Ingenuity has been adding abilities to our technique. I usually work with an assistant, a colleague. I use both of my hands for the forceps, and my colleague uses indents by one hand and obliquely illuminates by the other. The oblique illumination is very important to see the individual fibers. The coaxial lighting could be sometimes deceiving. The best is the oblique light. And lastly, we leave on the eye on Healon. We fill it with Healon and close it. So another speed up video, we work mid-periphery and then center. We try to locate the central stalk. Central stalk is usually very condensed vitreous, so I circumcise around it and then try to loosen its attachment until it comes out. We try to use the best instruments we have, very high quality, because to be able to catch good small individual fibers, and then you can see the indentation. The periphery here is very important. We find folds, we call it the gutters, and relieve as you can see here, the folds, we call it the gutters, and we try to relieve the folds. The periphery here is very important. We used to just free the center, but now we use the indentation to release also the peripheral traction, and it was very significantly affecting our success rate. It takes a little bit of time for the retina, if it flattens, to flatten. Usually we give them 3 months. If after the 3 months there are some residual traction, we can enter again. We try to continue and finish all of the traction, all of the surgery at one go, because the other surgery, during the other surgery, the fibrosis is a little bit tough. So these are the early cases with just a little bit of retina attached. But now if we say that the success rate, just 1 minute. If we say that the success rate is about 10 disc diameters, we have reached about 55% of success rate, which is okay. And we can finally see that the bilateral stage 5 ROP can walk around and catch objects. So don't lose hope, and thank you.
Thank you so much. I request the last speaker, Dr. Hayat Khan, to tell us about the new research in ROP.
Thank you, Dr. Subhadra, and thank you, our audience. Thank you, Myom, Dr. Amri. So I'll just be touching up some important parts, of course, not going much into detail because of the time constraints at the moment. But as things have evolved for the treatment of ROPs, and after the ETROP, where we defined the type 1 and type 2 disease, there came the time of using the anti-VEGFs, and I'm sure my colleagues have already taken up most of it. So straight on, I'll just concentrating about the new classification, which is so important for us to be using in our day-to-day practice. What is new? Of course, Dr. Hassan was mentioning, and that's very important to understand the posterior zone too. Why it is important? Its importance in terms of how we will manage our cases. I think that is also taken up, so I'm not going in detail. Sometimes there are notches which is incursion about 2 o'clock into the posterior pole sometimes, and then we would like to know about this, and we'd like to, of course, mention it in our findings. That's very important for all of us to. And always, while documenting the most posterior retinal vascularization or ROP lesion will be noted for the zoning of the eye. Now, in terms of plus disease, again, the new classification talks about how do we define the dilatation and tortuosity, and more pictures are there. We all have to go through them. We all have to understand them better. Then, of course, pre-plus disease, where abnormalities are there, but not as much as the plus disease. And then if more than one stages are seen, it's very important that we classify the most severe stages. Of course, we have to know about the term incomplete vascularization to be used in our notes, rather than conventionally we were using no ROP. And of course, as taken up by my esteemed colleague, we talk about how we classify the stage 5, the important understanding of peripheral avascular zone. All these are very important in our everyday practice. And of course, regression and reactivation, which is now a part of our ROP management with new invent of anti-VEGFs over period of time, understanding aggressive ROP instead of our previous defined aggressive posterior disease. So quickly I'll go in as far as the plus disease. Of course, as we go along over the time, we are now in a time that we are knowing about that we have to concentrate at the posterior zone, that is zone 1. And that is very important to define. Sometimes we see some pictures in some quadrant and you see the plus, then that doesn't mean that it is actually plus. So that's very important that we look at the whole picture at the posterior. Now going again, when we talk about the aggressive ROP, very important to understand. I'll show you a couple of slides on that. That is rapid development of pathologic neovascularization and severe disease without progression being observed through the typical stages. And that's very important that we do not miss on these cases. They are all there, and these are the ones who may have very high tempo and appearance of the vascular abnormalities. And of course, they are also, now we are including the large preterm infants beyond the posterior retina and large babies more than 1.5 kilogram. Now, I won't be going much in details, but of course, very important to know the hallmark of aggressive disease where there is prominent plus disease, featureless junctions, large vascular loops, flat extraretinal fibrovascular proliferation, and a very rapid course. So, very quickly, I'll go in that you can see that there is capillary non-perfusion, non-physiologic dilated vascular loops, which you see there, and these are associated with the atriovenous shunts, and of course, that you go ahead that these cases are I would say that you will see in your everyday practice, and we don't want to miss these cases. As you can see here, then again, this is another picture that is, so you'll see sometimes deceptively featureless networks, and of course, early contraction superiorly that you see in those white arrows. And then we're talking about these cases. It's all good to use a 20 diopter lens rather than just a conventional use of 28. So it should be a part of our armamentarium in our everyday practice. And we should not be shy of using the fluorescein angiography, which will be helpful in a lot of cases where you would be able to see the vaso-obliteration of the capillary and with non-perfusion. And Sometimes in these aggressive ROPs, no typical ROP lesions appear, and vasoattenuations, it appears right at the posterior to the ridge. This is another picture which actually signifies about how with anti-VEGFs when we treat, I'm not going in detail because of the time constraints. So definition of regression, of course, the disease involutes after giving either injection or the laser, and there is resolution. It may or not be complete, and of course sometimes include persistence of the retinal abnormalities, and we have to understand the reactivation, especially less common with the lasers, more common with the anti-VEGF injections. And quickly, when we talk about the aggressive ROP, we need to understand that the regression happens earlier in cases when we give injections. It takes a little longer to see after the laser. Thinning and whitening of the neovascular tissue can be noted, and that is one of the key things that we have to see once we have done the treatment. And anti-VEGFs reduce the dilatation before you see the tortuosity decreasing, and of course slower vascularization into the PAR is always there, and it's compared to the spontaneous regression once you have treated. There are other features that you'll see improving once you have regression, and always important that anti-VEGFs are more associated with PAR. And lastly, of course, I will be talking about the reactivation. This is more after anti-VEGFs. I am sure this was discussed with my colleagues. So typically, it originates at the ridge, at the leading edge of the intraarterial vascular growth, or both, or it may occur elsewhere within the vascularized retina. So very important to watch out, have regular checkups, at least till the first year, and if it's still there, then of course we need to treat these cases right away. And the choice of anti-VEGF has impacted the reactivation, especially if re-injected. And of course, these cases can progress into stage 4 and stage 5 with vitreous condensation, fibrotic contraction, and of course, a combination of it. So here's a quick picture. If you see that after being regressed at 38 weeks, at 51 weeks, reactivation can happen in a stage 3 ROP at the same site. And if you see the peripheral avascular retina, there is no vascularization seen in that area. So the new approach, of course, we have to see the morphology and the vascular development of macula. That is very important to see. We have to understand the pathophysiology and the rationale of individualized treatment, and I think that is what today's presentations were all about. And of course, the intensive care, how we manage them, also affects how we get the best out of our treatment. And lastly, especially keeping in mind with the pandemic situations, we have to know what we need to choose, especially between the anti-VEGFs and lasers, keeping in mind the follow-ups. Thank you so much.
Thank you. I think that was a great update. And if there are no burning questions, then we are almost on time, and then we are all available here outside the hall, and we can leave the hall for our colleagues, and we are there. We can discuss this further. Yeah, can we have a photograph of all the speakers before we disperse? Yeah, I'm coming. So I don't know where's the official photographer. If there's somebody here who can take a photograph.